This is an ABC podcast.
First, a taboo topic that's intensely personal. It's a common and debilitating condition, and the people who have it are often too embarrassed to seek treatment. I'm talking about fecal incontinence. You're about to meet Dulcie. She's 68 years old, and she's lived with this disorder for 20 years. And a heads up, this story goes into detail that some may find confronting.
I worked at a school, eventually as an assistant principal, but when I was in the classes, sometimes I'd get this urge to go, and when I had to go, it would be like I had 30 seconds to a minute to get wherever. I can remember one year 12 class they were doing a test, and I thought, what am I going to do? And I left it that sort of 30 seconds too long in making a decision. In the end, I dashed out of the classroom. By the time I made the nearest student toilet, it was too late. Then I had to virtually strip off, try and have a wash. Thank goodness the kids are in class and I could, have that in a little bit of privacy, but not really. Dumped half my things in a bin and I pulled the trousers back on and thought, well, here goes. This is an interesting day.
That's a common story for someone with fecal incontinence, difficulty controlling your bowel movements.
I would be in the supermarket, just about finished. I'd think, I can't wait. So I'd just dump my trolley in the supermarket and run, but a couple of times wasn't in time. And then, of course, you come back, you hope your trolley's still there, you pick your trolley up, you go through, you pay for it all, you go home and then you hop in the shower.
These accidents were intensely embarrassing for Dulcie, and they started to happen more often.
When it got to the stage where it was impacting on shopping, on going on a Sunday afternoon drive with my husband, etc., I realised I actually had a problem. I should have realised a lot earlier that it was a problem, rather than just thinking I had an upset tum. But things like that you don't expect to be happening till you're really old, and I don't consider myself really old just yet.
More on Dulcie's story in a minute. But first, what exactly do we mean when we say fecal incontinence?
The definition of fecal incontinence in simple terms is bowel accidents or bowel leakage. Someone cannot control the passage of stool.
This is Dr. Naseem Mirbagheri, a colorectal and pelvic floor surgeon who works in Melbourne.
And the definition is loosely used because it could refer to inability to control gas, which we call flatal incontinence. It refers to inability to control feces, which we refer to as fecal incontinence. Our typical person who presents with this problem tends to be a woman in middle age, menopause, maybe overweight, who's had multiple kids.
Men can have fecal incontinence, but it's reported more often in women, and their symptoms seem to be more severe. It's really common, but rarely talked about.
To my knowledge, there's at least 6 Australian studies that have attempted to estimate the prevalence of fecal incontinence in an adult Australian population. And in those studies, it has ranged from 10 to 20%. So in average, about 1 in 8 Australian people suffer from fecal incontinence. In fact, that figure can be as high as 50% in nursing home populations, so 1 in 2. The problem is this is probably an underestimation of this disorder because most people suffer in silence and don't seek help.
These are big numbers. Estimates can vary based on the study and how fecal incontinence is defined, but even conservative research says at least 2 in every 100 adults experiences fecal incontinence. And it becomes more common as you age and muscles in the pelvis weaken. In typical adults, the underlying causes of the condition are varied. Often it's connected to childbirth. Dulcie again.
They suspect that part of the issue started with the birth of my children. And it's interesting that when you're young and you have your family, no one ever explains to you what they've had to do, where they've had to stitch you, what damage has been caused.
A typical example is, for example, a woman who presents after birth, after a vaginal delivery, whereby she sustained a third-degree tear, for example. In that particular person, the underlying cause would likely to be a sphincter injury sustained during the birthing process. Either the injury has been missed or it has been repaired and has broken down.
Sometimes the problem isn't physical. It's an issue with the brain's connection to nerves that control the bowel and sphincter.
Patients with spina bifida is a typical example, or spinal cord injury, or diabetic neuropathy. So we classify it as neurogenic if there's a clear underlying neurological cause to it.
And you might be wondering, there is a large overlap between urinary incontinence, not being able to control your bladder, and fecal incontinence.
50% of patients with fecal incontinence also have urinary incontinence, and you can go the other way around because the pelvic floor and the pelvis itself contains 3 different organs, the rectum, the vagina and the bladder. When one dysfunctions, the other one also dysfunctions. So you can understand the ligaments supporting these structures support the other organs as well. So if you have a vaginal prolapse, for example, where prolapse by definition means something protruding out of its normal place, then you will also likely to have a rectal prolapse. So they go together, and that's why multidisciplinary management of this condition is absolutely crucial.
Someone who's had a different experience of fecal incontinence is Therese. Well, that's the name she wanted to go by. She oscillated between not needing to go at all and really, really needing to go.
Even just going to the toilet, sometimes I'd have difficulty, whether it was with constipation or just even more difficulty just cleaning myself when I went to the toilet, and urgency, thinking, oh, I've really got to find a toilet quickly, whereas, I was really able to hold on a long time for most of my life. I was passing wind a lot more, like involuntarily, and so they realised too there was a weakness in the bowel and the sphincter. I'm in the adult education sector. It's something that I'm very conscious of while I'm in front of a class of up to 20 students. It's not something that you want to have going on while you're, conducting class. What it brings up for me is sort of that whole thing of the smelly older woman. I don't want to be, considered to be a smelly old woman, but a lot of women are dealing with these problems every day of their life.
Therese visited her GP, who referred her on to a physiotherapist. The exercises she's been learning have helped manage her symptoms. There have been a few surprises along the way though.
The physio said at one point that I could use literally a butt plug. So if you've got a huge event and you don't want to worry about having flatulence, you might use one of those to guarantee things are pretty well safe, and you don't have to have that anxiety. The butt plug basically removes your anxiety. I haven't gone there yet. I can't believe I'm in this world. I can't believe I'm talking about this. I can't believe this physio has just suggested I use a butt plug. It's a whole world that is sort of the great unspoken, but it's so important that there's doctors out there that are doing an amazing job to help people keep their dignity.
The stigma and shame surrounding the condition can stop people from getting treatment.
I think every one of patients who come to me, they always tell me, I just wish I knew that there was help available. I was so embarrassed to talk about it. My partner doesn't even know about it. Or I've been thinking about talking to my GP, but I was embarrassed. And these people contend with socially isolating.
want a butterfly. Baby, you give me midnight. You whip up my appetite. Don't leave me here high and dry. Oh, well, I don't wanna jinx it, baby, and twist myself at the spine. Don't wanna overthink it, baby. It's just twist your body and mine. Baby, you give me ice and fire. You're giving me wind and rain.
Changes. Caffeine reduction, stopping smoking, losing weight, dietary changes, increasing fiber supplementation, for example, physiotherapy, helping patients do pelvic floor exercises. And those sort of things are really our first line treatment option.
Teresa's physical symptoms are relatively mild, so she's been undertaking these conservative first steps with the help of specialists. A lot of it's to do with healthy toilet habits, which sounds simple, but it can make a big difference.
What you're trying to do is to avoid constipation, because that then puts more pressure on the bowel and the pelvic floor. So the less pressure or effort you have to make when you have a bowel motion, the better. They also show you the best way to sit on the toilet. I'd never thought I'd have to be shown how to sit on the toilet, which sort of helps to open up the bowel without applying too much pressure on the pelvic floor from pushing.
Managing the condition is also about what you eat and the consistency of your poo.
The nutritionalist basically guides you towards food which is going to be keeping your stools soft, but not too soft, because if they're too soft, then you have more fecal incontinence because you've got diarrhea type of thing.
Loose stools, so diarrhea, is really an important, easily modifiable risk factor. So bulking up your stool, making sure you don't have intolerances to food that may cause you diarrhea, can improve symptoms in majority of patients. So simple measures like that could actually make a big difference.
When these conservative treatments don't work, people might look to more drastic action, like surgery. Sometimes that could be relatively straightforward, correcting a physical issue like a prolapse or hemorrhoids. But in cases where the condition is neurogenic, in other words, a breakdown in the connection between the brain and the bowel, things are more complex.
In patients who fail conservative treatment and who do not have a clear underlying anatomical abnormality that can be surgically corrected, next line treatment is what we call sacral nerve stimulation.
The idea of sacral nerve stimulation was raised to Dulcie after she reached a dead end with other doctors. Dr. Mir Bagari was her surgeon.
She then discussed with me this technique where you have, like a pacemaker, inserted into one of your cheeks, your buttocks, and a wire that is inserted into up near the spine area that then connects with the brain.
We use a small electrode to stimulate the nerves in the lower back in order to achieve continence or improve their symptoms.
This zapping of nerves is meant to encourage something called neuromodulation, but we still don't fully understand how it works.
One thing that we've concluded is a concept of central neuromodulation. It's a big word, but essentially what it means that we use peripheral stimulation, so stimulation in the nerves that's not directly linked to the brain, and we use that stimulation to create a process called neuromodulation. So we change the signaling in that nerve, which in turn changes this chemical signaling right in the brain. And we have found that changes in the brain is actually what happens with this particular procedure that results in continence.
Dulcie decided to have the device implanted. It's been a couple of months since the surgery, and so far it's been helpful.
It seemed to give me enough time to get to a toilet, either when I was at home or I was out at the shops. I didn't have any accidents at all in that time. The idea of being able to go places now and know that I will have time, I mean, so far it's been wonderful. I guess it's early days, but the fact that it's been wonderful already. I can't see that it's not going to keep working.
Many patients report life-changing results from sacral nerve stimulation, though it's not suitable for everyone, and more research is needed to establish whether it's effective long-term. Therese has chosen not to go ahead with surgery at this point. She's still managing her condition through diet and physiotherapy. But she urges others to seek out help if they start experiencing more severe symptoms or changes down there.
I want to encourage women not to put this off. It's important to look after yourself because women are notorious about, to put themselves last. Get onto it early. It's a bit like a car. I sort of think a little bit like a car. You notice a niggling, a little problem and you think, oh, it's fine. I won't take my car to the mechanic. I haven't got time, or it's going to cost a bit. And then, of course, a couple of years later or 12 months later, you realise, oh, hang on a minute, I'm up for quite a few thousand for a full reconditioned motor or something. So you need to get seen to look after yourself.
That was Therese, a woman with fecal incontinence. And my sincere thanks to both Dulcie and Therese for sharing those incredibly personal stories with us. On our end, the ABC Listen app, or wherever you get your podcasts, you're listening to The Health Report with me, James Bullen. And if that story struck a chord, we'd love to hear from you. Our contact details are on the Health Report website. You can find out more about incontinence at continence.org.au.